At this 4-hospital health systems, we have successfully implemented nursing documentation, electronic medication administration record, computerized physician order entry, barcode medication administration, longitudinal allergies and medication histories. We have now been approved for a full electronic medication reconciliation program into our EHR. This program compares a patient's medication orders to the medication the patient has been taking, which helps avoid adverse drug events. Medication reconciliation is done during every transition of care, including admission, transfer, discharge, and change of service, practitioner, or level of care. This new program will help us meet the criteria of the Meaningful Use Program to obtain more funding for our hospital.
We currently have a medication reconciliation process where we input patient allergies and home medications into the EHR. Then we print a paper report to do the medication reconciliation. This is easy to use and it only takes 5 seconds to reconcile a complex medication list. It even helps us make decisions, like which medications to continue or discontinue, and at each transition of care. I'm concerned that this new electronic version might have some discrepancies.
I was one of the pharmacists that was hired to strictly work with the new electronic medication reconciliation program. My job is to interview patients on admission and make a new discharge report. The idea is to have pharmacists do the medication reconciliation in order to improve medication outcome.
I would like to announce that since we are all so excited and eager to have this opportunity for advancement, we are waiving the small pilot program and implementing the computerized medication reconciliation system at all 4 hospitals at once.
This has been a disaster.
Workflow is constantly delayed. It usually takes 5 seconds to do a medication reconciliation, but with this new system, it's been taking 20 to 30 minutes.
I don't understand why they waived the small pilot.
The initial problem we were trying to resolve was how do we do a medication reconciliation during transition of care in order to minimize adverse drug events. Unfortunately, the electronic medication reconciliation system has caused work delays and a provider dissatisfaction. Hospital executives and I, the Chief Medical Information Officer, have decided to discontinue the use of this new program. We're holding this meeting today to discuss the concerns about the electronic medication reconciliation system. As we all know, this program was not successfully implemented, and we would like to hear your opinions.
I'm concerned that the implementation was not fully thought out. Having the hospitals implementing this program all at once caused chaos.
We realize the importance of the small pilot. We should have had it either implemented at one hospital or in a smaller department at first. Timely training and extensive support is important for change management. We need training that is high quality and specific to the needs of the user. Extensive support is needed on site for early implementation, and then it should be replaced by effective phone support once the initial demands decrease.
The old system worked great. It took about 5 seconds to do a medication reconciliation. This new system was not efficient since it took 20 to 30 minutes to do a complex medication reconciliation.
An important part of change management are the strategies used to facilitate the process of an organizational change. A strategy that we will use in the future is assessing workflow. We will evaluate the research the product before purchasing and implementing, and health informatics needs to see if the system will work within our specific organization. We will evaluate by using objective evaluation, where we compare a person using the information resources versus a person unassisted. This will determine whether or not the system is deemed beneficial.
It seems like we are strictly trying to meet the National Coordinator for Health Information Technology's meaningful use criteria, which do not take into consideration the different needs of the organization.
We may gain more funding by focusing on the meaningful use criteria, but fixing the problems the IT program causes can be more expensive than the funding gained. The leaders should take into consideration not just the funding, but the people that are using the IT program. They can do this by using subjective evaluation, where the healthcare professional's opinion can be heard while using the system. We realized that the implementation of the electronic medication reconciliation was not successful. We would like to use this as a learning experience. We found instances where electronic medication reconciliation systems have worked in the past, and we would like to outline the importance of them. In the article, Effect of an Electronic Medication Reconciliation Application and Process Redesign on Potential Adverse Drug Events, they had a controlled trial of a computerized medication reconciliation. There were 2 hospitals, 322 patients, 14 medical teams involved. There was a control group that didn't use the electronic medication reconciliation, and they ended up with a 1.44 adverse drug events per patient. The intervention group that did use the electronic medication reconciliation ended up with 1.05 adverse drug events per patient. This shows that although the computerized medication reconciliation programs may not completely eliminate the adverse drug events, it is still proven that using computerized programs will create less of a risk of adverse drug events. I'd like to introduce one of our hospital executives, and she'd like to say a few words.
So in the article, Reducing Medication Errors and Improving Systems Reliability Using Electronic Medication Reconciliation System, it talks about the effectiveness of a pilot program on an EMR. So the first did a 2-week pilot, the errors decreased to 20%. After evaluating again at 17 months, errors reduced to 1.4%. This group did a small pilot before implementing it at a bigger scale. Even during their bigger implementation, they called it an evaluation, where they are constantly monitoring its usefulness and efficiency. This showed that the medication errors and admission decreased significantly. The implementation of this was properly planned out and implemented, whereas the case we presented was not properly assessed before full implementation. This is our hospital executive, Natasha Cowan.
During our research process, we came across an article named A Collaborative Approach to Electronic Medication Reconciliation Improvement. This article talked about Trinity Health redesigning their medication reconciliation process. This would result in new standardized processes when used at every transition of care, which would help the organization be more patient-centric, reduce harm, and reduce safety measures. This article summarizes how this organization successfully used change management principles such as involvement, empowerment, and customer first. So these are the key learning points that we took away from the case. The first one is change management strategies are important for organizational change. We need this to help get users on board with the project. We found that change management strategies are crucial for addressing the concerns of healthcare professionals.
We also learned that evaluations are needed in order to assess whether or not an old workflow is better than the new workflow. We must ensure that the new features of the system will work efficiently with the organization. And in the case of the medication reconciliation, we must evaluate at every single transition of care to ensure the system's capabilities.
And finally, we learned that change management's 7 principles are a significant part of an organizational change. In this case, if these principles were used from the beginning, a lot of the problems would not have occurred.